We are Group 23. My name is Seema Khandagle,
My name is Sade Thesier.
and we will be presenting a critique of a study entitled Randomized Clinical Trial of Famciclovir or Acyclovir for the Treatment of Herpes Zoster in Adults.
Okay, so I just want to go through briefly what we're going to discuss today. So primarily, we're going to give you an introduction just based on herpes zoster, just pretty much the epidemiology of this disease. And we're going to go through the methods of the study where we're going to discuss the population, statistical analysis that were performed, some variables that influence the outcome, baseline descriptive statistics. We're going to go through the results. Both of us are going to provide our critiques, and we're going to conclude. And just for your reference, we're going to have some acknowledgments and references.
So let's get right into what is herpes zoster. So it's also known as shingles, and it's an acute eruption caused by the reactivation of varicella zoster virus. It affects one of 3 individuals, and it's more commonly seen in the elderly. However, it can affect you at any age. It spreads from the dorsal ganglia, affecting peripheral nerves and nerve roots, and it may interact with the spinal cord. So this causes intense inflammation in the skin, creating painful rash and lesions. And so the picture on the right actually shows the lesions and the rash and also the affected nerves. So therapy for this would be antivirals, and that's used for faster healing.
Okay, so there's various therapeutic options for herpes zoster. Primarily, what's currently used is acyclovir, valcyclovir, which is a prodrug of acyclovir, prednisone, famciclovir, which is a prodrug of penciclovir. Currently, what we see is that famciclovir has some pharmacokinetic properties and antiviral properties, which can make it superior in treating herpes zoster when compared to the more commonly used acyclovir.
So let's get into the methods. So the study design, it was a multi-center, randomized, single-blinded, active controlled study. It was conducted from December 2015 to July 2017 in Brazil. And so it followed patients for 28 days with intermediate visits on days 7 and 14. So the overall research question of this study is famciclovir equally safe and effective in comparison to acyclovir in treating patients with uncomplicated herpes zoster?
Okay, so the study had pretty specific inclusion and exclusion criteria. So for inclusion criteria, pretty much the study wanted patients who had uncomplicated herpes zoster, which is defined as a unilateral vesicular rash affecting 1 to 3 adjacent dermatomes. They also wanted immunocompetent adults, so pretty much patients that are over the age of 18. A score of 40 millimeters on visual analog scale, also known as VAS, for at least 2 of the following symptoms and signs, which is pain, loss of sensitivity, burning, and pertussis. And for the exclusion criteria, uh, the study didn't want patients who possessed certain qualities, such as clinical diagnosis of severe herpes zoster infection, a history of hypersensitivity, or any kind of allergic reaction to famciclovir or acyclovir, previous use of antivirals or corticosteroids, severe systemic disease, and then breastfeeding or pregnancy.
So, for the population, a power analysis was done and reported. It assumed a dropout rate of 10% after randomization, 75 participants in the famciclovir, and 76 patients in the acyclovir treatment groups, and with a total of 151 total participants. According to these statistics, 80% was the power analysis reported. Overall, the study population did encompass our target population, and those were individuals affected by herpes zoster.
So various statistical analysis tests were used. Just to list some, there were the Kaplan-Meier method, Cox proportional hazards model, Fisher's test, Levine's test, independent t-test, and essentially these analyses were performed in the per protocol population. So essentially, they wanted to include patients that were more compliant with protocol.
And so to get into the variables, the independent or treatment variables were either famciclovir 50 milligrams, 500 milligrams 3 times a day for 7 days, or acyclovir 800 milligrams 5 times a day for 7 days. The dependent variable, the primary outcome, was the time to full crustation of the herpes zoster lesions. And the secondary outcomes that the study also assessed were the proportion of patients achieved a complete cure, and a change in VAS scores of the signs and symptoms.
So there are also various variables, confounding variables or covariates. Um, so uh, Also that was put into consideration were racial demographics, any kind of comorbidities such as chronic health conditions, age, time to start the therapy since the outbreak, alternative interventions such as analgesics and antipruritics or anti-itch medications, and adverse events of therapies.
So here we have the baseline descriptive statistics of each of the treatment groups at baseline. So a Fisher's test and a t-test were used to compare participants at baseline. More than half of the study participants were female with a percent of 64.9. The median age was 59 years old, with a range of the youngest being 18 and the oldest being 92. And also the mean baseline VAS scores are shown here at the bottom of pain, vesicular lesions, loss of sensitivity, burning pain, and itch. The p-values on the rightmost column are all greater than 0.05, meaning the difference between the two groups are due to chance alone. So there was no clinically significant difference at baseline.
Okay, so the efficacy of parameters were analyzed using the Kaplan-Meier method. Um, Cox proportional hazards models were used to determine differences in treatments, considering treatment, age, sex, and baseline pain as covariables. Um, so essentially, there wasn't like a real significant difference seen, as the mean time to full crusting in herpes zoster lesions, for acyclovir it was 15 days, and famciclovir was close to 15 days at 14.8 days. For the secondary outcome, similar proportions of patients in each treatment group were also observed, which further confirmed the non-inferiority of famciclovir to acyclovir. So, as we can see here, it for the rate of achieving complete cure, acyclovir was at 94.74%, and famciclovir was at 94.67%, which had a small difference of just 0.07%.
So here we have more results from another secondary outcome, and this included the VAS scores of signs and symptoms at day 7, 15, and 28. A Levine's test and a t-test was done to compare these scores at each of the follow-up periods, with the inclusion of 0 in the 95% confidence interval in the red square outline shows that these results were not statistically significant, and that goes throughout all of the scores found over the study period.
Okay, our overall critique of this study. We want to start out with the study strengths. So it was a computer generated randomization. So this reduced any kind of incidence of bias. Um, the power was of 80%, which was an acceptable sample size. It was a single blinded study, so patients essentially weren't were unaware of treatment therapy. And groups were similar at baseline from given characteristics, and this can be seen on slide 11 where we discuss the baseline descriptive statistics.
And so now we will get into the weaknesses of the study. There was an underestimation of dropout rate. It was stated previously that it was estimated to be a 10% dropout rate. However, when we actually calculated it, it was around 13 to 14%, and this can have an effect on the power analysis done. There was also low external validity, as it was just a study done in Brazil. There was no racial information given about the patients, and how can we apply these outcomes worldwide. Race and past medical history was also left out at baseline, as I said previously. Blinding of treatment was insufficient, as mentioned. So famciclovir and acyclovir were given at 2 different frequencies, one at 3 times a day, one at 5 times a day. It's pretty obvious what treatment option you are going to be in. Other interventions possible and not adjusted for. So interventions such as analgesics used or anti-itch medications used, this could affect the VAS scores that were reported in the study. There were also co-founders and covariates that were not adjusted for, and those were previously mentioned in our presentation. Outcomes and exposure measurements were not methodologically sound. It was not reported on how herpes zoster was diagnosed. Also, patients self-reported their VAS scores in a daily diary. This can be exaggerated or underestimated, and also given the patient population being in Brazil, are they more prone to pain tolerance than the general population? Adverse events were reported but not statistically tested. So we believe when you're analyzing one treatment option over the other, it's important to go into adverse events. Although reported, we don't know if they were statistically different. And also a per protocol analysis was used, so it only included patients that were adherent to the protocol and not really significant of what we would actually see in the community.
Okay, so essentially in this study, the author concluded that there wasn't a real difference seen between the efficacy of the treatments between famciclovir and acyclovir for uncomplicated herpes zoster. There wasn't a huge difference that was significant enough to be seen clinically and relevant based on the effects on time to be healed, lesions, complete cure, and signs and symptoms. So, in reference to the clinical significance, famciclovir 500 milligrams 3 times a day for 7 days is an equal alternative to the traditionally prescribed acyclovir antiviral for herpes zoster.
So our overall critique, we've come to the conclusion that it is a weak study, and so how the authors or future scientists can improve this study is by taking those weaknesses we discussed previously and making some improvements. So first on our list would be to adjust for differences in frequency of oral dosing, 3 times a day versus 5 times a day. Maybe an inclusion of a placebo tablet or something to that effect, that it wouldn't be obvious to the patients what medication that they're on. Also, adjust statistically for alternative treatments of signs and symptoms. We talked about analgesics for pain, anti-itch medications, as these affect the VAS scores that patients are reporting on. Categorize age. It is known that herpes is more common in the elderly, and it does affect them differently as well. So maybe categorizing the age component. Assess patients based on other health conditions. So other conditions, with them being immunocompromised, other heart conditions. Also, inclusion of a protocol and guidelines of diagnosis and improvement of outcomes. So what I mean here is guidelines on how herpes zoster was diagnosed, make sure it's the same throughout the study for every patient, and how the VAS scores and improvement, how they were assessed, how lesions were assessed, and also that should be reported every day for the 30-day period. analyze adverse events. Like we said previously, adverse events are important to know about when we're assessing safety and efficacy of one treatment over the other. And also using intention to treat analysis. So by using intention to treat analysis, you get a closer picture of adherence seen in the community. And that can be used to inform community-based decisions about effectiveness of treatment.
Okay, so we just wanted to take the time out to acknowledge Dr. Wingate and Dr. Maneno for giving us this opportunity to further expand our knowledge on herpes zoster and to further strengthen analyzing statistical studies. And these are just our references. Thank you.
Thank you.